Relapsing polychondritis, RP, is a rare, chronic autoimmune disorder characterized by recurrent inflammation of cartilage and other tissues throughout the body. The exact cause of RP is unknown, but it is thought to involve an immune system attack on the body's own cartilage. Key features: cartilage inflammation. RP primarily affects cartilage in areas like the ears, nose, trachea, windpipe, and joints. Fluctuating course. The disease is marked by episodes, relapses, of inflammation followed by periods of remission. Multi-system involvement. In addition to cartilage, RP can affect the eyes, blood vessels, heart valves, and kidneys. Common symptoms: ear pain and redness. This is often one of the earliest and most common symptoms, affecting the outer ear cartilage, sparing the earlobe. Nasal involvement. The nose can become inflamed, leading to pain, and in severe cases, a saddle nose deformity. Joint pain, arthralgia. Joints may be painful and swollen. Respiratory issues. Inflammation of the trachea and bronchial tubes can cause breathing difficulties, wheezing, or cough. Eye inflammation. In some cases, inflammation of the eye, scleritis, uveitis, occurs. Diagnosis. Diagnosing RP can be challenging due to its rarity and the wide range of symptoms. There is no specific test for RP, so diagnosis is usually based on clinical findings, history, and exclusion of other conditions. Treatment. Medications. Treatment often includes nonsteroidal anti-inflammatory drugs, corticosteroids, and immunosuppressive agents like methotrexate or azathioprine to control inflammation. Monitoring. Regular follow-up is necessary to monitor disease activity and adjust treatment as needed. Prognosis. The prognosis of RP varies depending on the severity and extent of organ involvement. While some people experience mild, manageable symptoms, others may face life-threatening complications, especially if the respiratory tract or cardiovascular system is affected. Because of its complexity and potential for multi-system involvement, RP management often requires a multidisciplinary approach, involving specialists in rheumatology, pulmonology, ophthalmology, and other fields as needed. Yes, stridor can be a presenting symptom in relapsing polychondritis RP, particularly when the disease affects the respiratory tract. Stridor is a high-pitched, wheezing sound caused by obstruction or narrowing of the airway, and in RP, it typically results from inflammation of the cartilage in the trachea, windpipe, and bronchi. How stridor occurs in RP? Tracheal and laryngeal involvement. Inflammation of the trachea and larynx, which are both supported by cartilage, can lead to narrowing of the airway, causing stridor. This is particularly concerning because it can lead to breathing difficulties and, in severe cases, life-threatening airway obstruction. Bronchial involvement. Inflammation can extend to the bronchi, further contributing to respiratory symptoms. Clinical significance. Respiratory complications. Stridor is an alarming symptom in RP and usually indicates significant involvement of the respiratory tract. It requires prompt medical evaluation and treatment to prevent complications like airway collapse. Urgent care. Patients presenting with stridor should be evaluated for airway patency, and severe cases may require interventions like corticosteroids, immunosuppressive therapy, or even surgical procedures, e.g. tracheostomy, to secure the airway. Because of these potential complications, early recognition and treatment of respiratory involvement in RP are crucial. Yes, stridor can occur in relapsing polychondritis RP, even in the absence of typical cartilaginous features such as ear or nasal involvement. Although RP is often associated with visible inflammation of the auricular, nasal, or joint cartilage, some patients may initially present with respiratory symptoms, including stridor, without any other obvious signs of cartilage inflammation. How this happens. 1. Primary respiratory involvement. In some cases, the disease may predominantly or initially affect the cartilage of the trachea, larynx, or bronchi without manifesting typical features in other cartilaginous structures like the ears or nose. This can lead to airway narrowing, which presents as stridor. 2. Delayed or atypical presentation. Some patients with RP may have a delayed onset of more recognizable symptoms like auricular or nasal chondritis. This atypical presentation can lead to delayed diagnosis, especially when respiratory symptoms like stridor are the primary or sole manifestation. 3. Misdiagnosis risk. Stridor without other typical RP features might lead to an initial misdiagnosis of other conditions, such as asthma, croup, or other causes of airway obstruction. Therefore, clinicians must consider RP as a differential diagnosis in cases of unexplained stridor, especially if the patient eventually develops additional features suggestive of the disease. Clinical implications. Early diagnosis. Recognizing that stridor can be an early or isolated sign of RP is crucial for early diagnosis and treatment, which can help prevent severe airway complications. Multidisciplinary approach. If RP is suspected in the absence of typical features, involvement of rheumatologists, pulmonologists, and otolaryngologists is important to ensure comprehensive evaluation and management. In summary, stridor can be an early or isolated feature of RP, even without typical external cartilaginous symptoms, and such cases require careful evaluation to prevent misdiagnosis and ensure proper treatment. The treatment of relapsing polychondritis primarily focuses on controlling inflammation, alleviating symptoms, and preventing complications. Given the variability in the severity and organ involvement of the disease, treatment is often tailored to each patient's specific needs. Here's an overview of the treatment approaches. 1. Medications, nonsteroidal anti-inflammatory drugs, NSAIDs, used for mild symptoms like joint pain and inflammation, may help control discomfort and reduce inflammation in milder cases of RP. Corticosteroids. Prednisone is commonly used to reduce inflammation quickly. It is the mainstay of treatment during acute flares. The dose depends on the severity of the disease, with higher doses used for more severe or life-threatening involvement, e.g., respiratory or cardiovascular complications. Gradual tapering of the dose is usually attempted after achieving disease control, but some patients may require long-term low-dose corticosteroids. Immunosuppressive and disease-modifying anti-rheumatic drugs, DMARDs, methotrexate, azathioprine, cyclophosphamide, mycophenolate mofetil, or cyclosporin, are often added to reduce the need for long-term corticosteroid use and to control disease in patients with more severe or refractory cases. These medications suppress the immune response and help control inflammation over the long term. Biologic agents. TNF inhibitors, e.g., infliximab, etanercept, rituximab, or tocilizumab, may be considered in severe cases, particularly if there is poor response to conventional immunosuppressants. These targeted therapies are used in cases with significant systemic involvement or when other treatments are insufficient. 2. Management of specific organ involvement. Airway involvement. High-dose corticosteroids and/or immunosuppressants are critical for managing tracheal, laryngeal, or bronchial involvement that may cause airway obstruction. Severe cases may require surgical intervention, such as tracheostomy or the use of airway stents, to maintain airway patency. Cardiovascular involvement. Involvement of the heart valves or blood vessels may require aggressive immunosuppressive therapy. Surgical intervention, such as valve replacement, may be necessary in cases of significant valve damage. Ocular involvement. Corticosteroid eye drops or systemic corticosteroids are used to manage inflammation in the eyes. Severe cases of scleritis or uveitis may require systemic immunosuppressants. Hearing loss. RP can cause sensorineural hearing loss. Corticosteroids are often the first line of treatment, and hearing aids may be necessary for permanent hearing loss. 3. Lifestyle and supportive care. Patient education and monitoring. Patients should be educated about the chronic nature of RP, the potential for relapses, and the importance of regular follow-up to monitor disease activity and treatment side effects. Physical therapy. This can help maintain joint function and mobility, especially in patients with significant joint involvement. Psychological support. Managing a chronic condition like RP can be stressful. Psychological or counseling support may be helpful for some patients. 4. Surgical interventions, airway surgery. In severe cases of tracheal or laryngeal involvement, surgical procedures such as tracheostomy or airway stenting may be required to prevent life-threatening airway obstruction. Reconstructive surgery. Patients with severe deformities, such as saddle nose deformity, may benefit from reconstructive surgery. 5. Multidisciplinary care. Given the multisystem nature of RP, a multidisciplinary approach is essential. Patients may need to be seen by rheumatologists, pulmonologists, otolaryngologists, ophthalmologists, cardiologists, and other specialists based on their specific organ involvement. Summary. Treatment for RP ranges from NSAIDs for mild cases to high-dose corticosteroids, immunosuppressive agents, and biologics for severe or life-threatening involvement. The goal is to control inflammation, prevent complications, and improve the patient's quality of life. Regular monitoring and a multidisciplinary approach are often necessary to manage the disease effectively.